The digestive system allows us to take in and absorb nutrients. The major structure of the digestive system is the alimentary canal. This is also known as the gastrointestinal tract or the GI tract, and even known as the gut. The alimentary canal digests and absorbs food, and it is basically one long tube: mouth, pharynx, esophagus, stomach, small intestine, and large intestine. Associated with the alimentary canal are certain accessory organs. These organs assist in the digestive processes: the teeth, the tongue, and the gallbladder, as well as the digestive glands, the salivary glands, the liver, and the pancreas. Here you basically see the tube, one long tube that stretches from mouth to anus, and you have accessory organs outside the tube that are capable of contributing solutions to the tube: the salivary glands, the liver, here's the gallbladder, here's the pancreas. The teeth and tongue, of course, are located in the mouth. There are 6 major digestive processes: ingestion, or the taking in of nutrients; propulsion, which has to do with swallowing, and peristalsis, moving the food through the system; mechanical breakdown, performed by chewing and segmentation; digestion, which are the chemical processes involved in breaking large molecules into smaller molecules that can be absorbed. And then finally there's defecation, the elimination of undigested material from the digestive system. These processes are outlined on this picture. Ingestion only occurs at the mouth. Mechanical breakdown occurs several places: chewing in the mouth, churning in the stomach, segmentation in the small intestine. Digestion can occur starting in the mouth, a little bit in the stomach, but primarily in the small intestine. Propulsion begins in the mouth with swallowing, and then peristaltic activity keeps the food moving through the system until defecation occurs. Absorption primarily occurs in the small intestine, where the nutrients enter either the blood or the lymph. And finally, the rectum and anus eliminate the undigested particles in the process of defecation. There are 2 basic muscular activities that occur in the digestive system. One is peristalsis, and in peristalsis, the circular muscles of the tube contract one right after the other, so that the bolus of food is pushed through the tube. The other type of muscle contraction is segmentation. Non-adjacent circular muscles sort of close off the tube, and then the muscles here massage the food, mixing it a little bit. Then after a little while, some different circular muscles close off the tube, and a new segment is formed, and the material there is massaged for a while. We go back and forth between these two until all of this food is sort of uniformly mixed. Then there will be peristaltic activity that will clear everything out. New material will come into this area, more segmentation will occur. This is one of the mixing and mechanical breakdown functions of the digestive system. Most of the digestive organs are in the abdominopelvic cavity. This is a closed cavity, so there is a serous membrane lining the cavity and covering the organs of the cavity. This membrane is known as the peritoneum. The parietal peritoneum lines the cavity, and the visceral peritoneum covers the organs. The peritoneum produces peritoneal fluid, which acts as a lubricant so that the 2 membranes slide easily over each other. There is also a special feature of the peritoneum called the mesentery. Your body plan is described as a tube in a tube. Basically, your body is a tube, and your digestive system is a tube that runs through your body. The parietal peritoneum lines the abdominal cavity. The visceral peritoneum covers the organs. Since basically this is a tubular set of organs, the visceral peritoneum has to extend from the posterior abdominal cavity, surround the tube, and then return back to the parietal peritoneum. This is called the dorsal mesentery, and what you have is a double layer of peritoneum between the abdominal wall and the tube that's been surrounded by peritoneum. Some organs are also suspended in ventral mesenteries, that is, extensions of the peritoneum that come from the anterior wall. These ventral mesenteries have special names. They're called omentum. Sometimes they're even called ligaments, and these are nothing like the ligaments you're used to thinking about in your joints. Some organs are outside of the peritoneal cavity. We say that those are retroperitoneal. The mesentery, that double layer of peritoneum from the abdominal wall to the organs, acts as an avenue for nerves and blood vessels. Here is the abdominopelvic cavity and the peritoneum. As the peritoneum leaves the back wall, it comes out, surrounds the tube, and goes back. This is your mesentery. There are some instances where we have a ventral mesentery that comes out from the front, the anterior wall, and will cover and suspend organs that way. A few things are outside of the peritoneum. These are your retroperitoneal organs. Peritonitis is an inflammation of the peritoneum. Anything that pierces the peritoneal cavity would cause this. So any kind of piercing abdominal wound, a perforating ulcer, poor sterile technique during abdominal surgery, or a ruptured appendix. And a ruptured appendix is the most common cause of peritonitis. In any of these situations, bacteria from the gut enter the sterile peritoneal space. Now, the peritoneum tends to stick together around the area that's been damaged, and that sort of walls off the infection, helping to localize it. This gives the immune system a chance to come in and try to contain it. However, if that doesn't work and the peritonitis becomes widespread, this is a life-threatening infection. The treatment is to remove the infected tissue and then give megadoses of antibiotics. The tube of the alimentary canal has 4 tunics or layers. The innermost layer is the mucosa. Its function is to secrete mucus, absorb nutrients, and protect the underlying layers. The mucosa is composed of epithelial tissue. It changes its type throughout the system. It is sometimes simple squamous, sometimes cuboidal, sometimes stratified squamous, or columnar tissue. The submucosa is the next layer. This is primarily areolar connective tissue. There's a rich blood supply here, a rich supply of lymphatics. The malt tissue is here, and there are also nerve fibers and elastic fibers. The muscularis externa is the muscular layer. There are 2 layers of muscle, a longitudinal layer and a circular layer. These are the muscles that are involved in segmentation and peristalsis. And then the outermost layer is the serosa. The serosa is also the visceral peritoneum. So here you see the digestive system in cross-section. Here is that internal mucosal layer. There is a thin, smooth muscle wall that's associated with this that allows this to quiver a little bit. Here is the submucosa with all of the glands in it and some of the nerves and the blood vessels. Then here is the muscularis externa, and the muscularis externa also has nerves and blood vessels to it. Then the outermost layer, the serosa, is your visceral peritoneum. Here's the mesentery, and you can see that the blood vessels and nerves are traveling in the mesentery to get to the tube. The splagnic circulation is what supplies blood to the digestive organs. The arteries that branch off the abdominal aorta serve the digestive organs. These would be the celiac, the superior mesenteric, the inferior mesenteric. And then blood is drained from these organs by the hepatic portal system so that the nutrient-rich blood is taken to the liver for processing before entering the systemic circulation. The digestive system also has its own nervous system, the enteric nervous system. This is sometimes called the gut brain. This is an in-house nerve supply that serves the alimentary canal. It is responsible for the motility and glandular activity of the digestive system. There are 2 nerve plexuses, the submucosal nerve plexus, which goes to the submucosal layer, and the myenteric nerve plexus, which goes to the muscularis. The enteric nervous system participates in what are called short reflexes, which are reflexes that are entirely controlled by the enteric nervous system, but it also plays a role in what are called long reflexes. That is, sometimes the enteric nervous system sends information to the central nervous system for integration, and then extrinsic autonomic nerves bring information back to the digestive system. So we can have external stimuli that can stimulate the central nervous system, having it communicate with the gut brain, the intrinsic nervous system. We can have internal GI tract stimuli that stimulate chemoreceptors, osmoreceptors, and mechanoreceptors in the intestine. These may directly cause the enteric nerves to have smooth muscle or glandular activity occur, Or this may go to the central nervous system for it to process, and then using the autonomic nervous system stimulate the gut brain to cause the smooth muscle or the glands to operate. Digestive activity is provoked by a number of mechanical and chemical stimuli. The receptors are located in the walls of the GI tract. These receptors are for stretch, osmolarity, and pH of the contents of the lumen of the intestine. The presence of substrates or the presence of end products of digestion will also stimulate the chemoreceptors. Effectors of digestive activity are the smooth muscle of the muscularis and the glands that are located in the submucosa. Also, the accessory glands can be affected. Neurons may be either intrinsic or extrinsic. They can either be the gut brain or from the autonomic nervous system, and hormones, largely produced by the gastrointestinal system, control digestive activity. The major structures of the alimentary canal are the mouth and the accessory organs found there, the esophagus, the stomach, the small intestine, the large intestine, and the rectum. The accessory glands that assist with digestion are the salivary glands, the gastric glands, and the liver and the pancreas. The mouth, also known as the oral or buccal cavity, has in it several accessory organs. One is the tongue. The tongue is anchored to the floor of the mouth by the lingual frenulum. Located on the surface of the tongue are the taste buds. Taste buds make eating more enjoyable. Also, the tongue helps mix the food with saliva to form a bolus. A bolus is a sticky mass of food. If you have kids, you've had these spit into your hand numerous times. And the tongue initiates swallowing. Some children are born with a condition called ankyloglossia. They're literally tongue-tied. Their lingual frenulum is too short, and it does not allow them to have free movement of the tongue. This is corrected surgically by simply clipping the lingual frenulum a little bit. Children with this have difficulty speaking and eating, so they need to have this fixed fairly soon. The salivary glands are also associated with the mouth. They secrete saliva. Saliva has several functions. It helps cleanse the mouth. It dissolves food chemicals so that they can get to those taste buds and be tasted. And it moistens the food to make a bolus. Saliva also contains a digestive enzyme known as amylase. This is the enzyme that will begin the breakdown of carbohydrates. There are three major salivary glands. One of them is the parotid gland, and the parotid gland is the site of a viral infection that leads to mumps. Mumps is a relatively mild disease in children. Their neck swells slightly as a result of the infected parotid glands. However, in older males, the virus may also attack the testes, leading to sterility. The minor salivary glands secrete saliva constantly. This keeps the mouth moist. However, food entering the mouth will stimulate the major glands, and salivary output will increase greatly. Salivary output is controlled by the parasympathetic nervous system. Food being placed in the mouth stimulates chemoreceptors and mechanoreceptors. These signals are sent to the brainstem, the pons, and the medulla, and this causes an increase in a watery, enzyme-rich saliva. The chemoreceptors for acid are the ones that will most strongly activate the salivary glands. Mechanoreceptors are activated by any mechanical stimulus in the mouth. Kids that have braces, when they have their braces tightened, for a day or two afterwards they drool because they've got extra mechanical stimulus in the mouth from that tightening of the braces. The sight or smell of food may stimulate receptors. That concept of that's mouth-watering. Irritation of the lower GI tract by bacterial toxins or spicy food or hyperacidity will also stimulate salivation. The extra saliva tries to wash away or neutralize the irritant. The sympathetic nervous system will stimulate the production of a thick, mucin-rich saliva. This really makes the mouth feel dry. Dehydration will also reduce saliva production. Anything, whether it's dehydration, the sympathetic nervous system, or some drugs that inhibit saliva production promotes tooth decay and halitosis or bad breath. That cleansing feature of the saliva helps keep bacteria washed off the teeth. That reduces tooth decay. Also, keeping the mouth moist helps limit the kind of bacteria that grow. The teeth are located in the mouth, and it is the teeth that start mechanical breakdown of food. Mastication, or chewing, cuts and grinds the food. Everyone has two sets of teeth. The deciduous or baby teeth start to appear at about 6 months. Permanent teeth are developing deep in the bone sockets of the jaw. They push out the baby teeth between the ages of 6 and 12. A full set of teeth is 32 teeth. The very back molars, which are called the wisdom teeth, do not always erupt. Impacted teeth are teeth trapped in the jawbone. As they try to erupt, they give painful pressure. Usually the wisdom teeth are the ones that are most likely to be impacted, and they may have to be surgically removed. The exposed part of the tooth, or the crown of the tooth, is covered in enamel, which is an incredibly hard substance. The root of the tooth is embedded in the jawbone. Cement is the calcified connective tissue that covers the root and attaches the root to the periodontal ligament. This anchors the tooth in the jaw socket. This provides you with a joint called a gymphosis. The bulk of the tooth is composed of dentin. This is what is immediately under the enamel. Dentin surrounds the central pulp cavity, which contains connective tissue, blood vessels, and nerves. Dental caries or cavities occur when the enamel is damaged in some way. A common way the enamel is damaged is as the result of bacterial activity. Bacteria produce acids from sugars that may be left in the mouth after swallowing. These acids will etch the enamel, weakening it. Bacteria can then break into the dentin and begin to decay the inside of the tooth. Gingivitis is when calculus separates the tooth from the gum. Calculus is a hard material that can build up on the teeth. This does two things. One, it sort of covers up the bacteria, actually keeping them attached to the tooth so they can actually do damage more, but it also irritates the gum. Periodontal disease or periodontitis is what can occur if gingivitis goes untreated. Periodontal disease causes the tooth and the gum to separate, exposing the root and making the tooth more likely to fall out. The oropharynx and the laryngopharynx, you'll remember, are passageways for food as well as air. The muscles of the throat propel the food to the esophagus. The throat, remember, has voluntary muscle in it. The esophagus is a muscular tube. This is where the 4 layers of the alimentary canal begin. The esophagus travels through the thoracic cavity and goes through the diaphragm at a place called the esophageal hiatus. It joins the stomach at the cardiac or gastroesophageal sphincter. Heartburn occurs if the acid contents bubble back up into the esophagus. The esophagus is not designed to handle the acidity, and so the burn actually occurs. It's called heartburn because the esophagus goes very near the heart at this point, and it sometimes feels like pain in the heart. Heartburn is frequently the first symptom of gastroesophageal reflux disease, or GERD. Frequently, heartburn is caused by people who overeat and then lie down too soon. A hiatal hernia occurs when the hiatus, the hole in the diaphragm, is larger than it should be. The stomach can then protrude up through the diaphragm. This will also cause heartburn because the acid contents will regurgitate back up into the esophagus. This can be surgically repaired. The mouth is the only site for ingestion. Also, mechanical breakdown begins here with the teeth and the tongue working on the food. We start chemical digestion in the mouth with the amylase in the saliva beginning to work on carbohydrates. And then propulsion begins here because the mouth is involved in the swallowing or deglutition of the food. Swallowing is a coordination of 22 different muscle groups. In the buccal phase, the bolus is voluntarily forced into the oropharynx. Then the pharyngeal and esophageal phase occurs. This is when involuntary muscles take over and peristalsis begin. Basically, the pharynx and the esophagus are simply conduits to the stomach. The stomach is a temporary storage tank for food. Chemical breakdown of protein begins here, and the mechanical breakdown that occurs here turns the material that enters the stomach into a paste-like substance known as chyme. The stomach holds 50 milliliters to 4 liters. 4 liters is about a gallon. There are rugae or folds in the inside of the stomach that allow for the stomach to expand greatly. The stomach can be divided into 4 regions: the cardia, which is where the esophagus attaches, the fundus, the body, and the pyloric part. There are also two curvatures on the stomach, the greater curvature and the lesser curvature. The lesser omentum is the double peritoneal layer that attaches the liver to the lesser curvature, and the greater omentum is the double layer of peritoneum that drapes from the greater curvature and covers the intestine. The greater omentum usually has fat pockets in it. This helps insulate the intestine and give it some additional protection. The stomach also has 3 muscle layers instead of 2. So here you see the esophagus coming down. Here would be the gastroesophageal sphincter, and this is the cardiac portion of the stomach. The fundus crowns up a little bit. This would be right up under the diaphragm and the heart. Here's the body of the stomach and the pyloric region. The lesser curvature and the greater curvature. And you see the layers. Notice that there are 3 muscular layers. These folds are the rugae. The stomach has all 4 tunics, but the muscularis and the mucosa are modified for special functions. The muscularis still has the circular and longitudinal layers, but it also has an incomplete inner layer of oblique muscles. This allows the stomach to mix, churn, propel, and pummel the food. The mucosa is a simple columnar epithelium that is made of mucus cells. These mucus cells produce a cloudy, protective 2-layer coat of alkaline mucus. Dotted along the lining are the gastric pits, and the gastric pits lead to tubular gastric glands that produce gastric juice. The cells that form the walls of the gastric pits are mostly mucus-producing cells, but there are different secretions found in different areas of the stomach. There are different types of cells found in the glands. The mucous neck cells produce a thin, soluble mucus that's acidic in nature. We haven't quite figured out the function of this particular secretion. The parietal cells secrete hydrochloric acid. This is responsible for the acidity of the stomach. The stomach has a pH between 1.5 and 3.5. This acid pH is necessary to activate pepsin, which is the enzyme that digests protein. Also, the acidity helps denature the proteins, breaking them down a little bit before the enzymes get to them. And it kills many of the bacteria that's ingested with the food. The chief cells secrete pepsinogen. Pepsinogen is an inactive form of pepsin. They also secrete a little bit of lipase, and lipase will break down fats, but the pH in the stomach is really wrong for the lipase to work, so lipase activity is very limited. The enteroendocrine cells release a variety of chemical messengers. These are hormone-releasing cells. The hormones they release are histamine, serotonin, somatostatin, and gastrin. Now here you see the surface of the stomach, and these are the gastric pits leading to these tubular gastric glands. The chief cells, the parietal cells, and the mucous neck cells. The enteroendocrine glands are only found in the pyloric region. Gastric juice is highly corrosive, and protein digestive enzymes are found in the stomach. Those protein digestive enzymes would digest your stomach tissue, so we have to be very careful about keeping them inactive until they really have something to work on. The stomach lining is protected by a mucosal barrier layer. This is a thick coating of bicarbonate-rich mucus. It builds up on the stomach wall. Those mucus cells produce it. Also, the epithelial cells of the stomach lining have very tight junctions between them, so things can't get through or between the cells. Damaged epithelial cells are shed and quickly replaced. There's a group of stem cells at the edge of the gastric pits that can reproduce and manufacture new epithelial cells. The lining of the stomach is completely renewed every 3 to 6 days. Gastritis is an inflammation of the stomach lining. This occurs if that mucosal barrier is breached. Peptic or gastric ulcers are erosions in the stomach lining. Symptoms are pain 1 to 3 hours after eating that is relieved by eating. Stress, acidic foods, and various medications have been blamed for causing ulcers, but about 90% of ulcers are caused by the bacterium Helicobacter pylori. About 50% of people harbor this organism, but only 10 to 20% will ever experience pathological effects. To diagnose Helicobacter pylori, there's a simple breath test. This organism releases a lot of urea, and you can detect the urea in the breath. Because this is a bacterial infection, you can treat it with antibiotics. The few ulcers that are not caused by H. pylori are caused primarily by the long-term use of non-steroidal anti-inflammatory drugs or NSAIDs, things like aspirin or naproxen. You treat these ulcers by blocking hydrochloric acid secretion. Mechanical breakdown occurs in the stomach because of the muscle activity of the 3 layers of muscle in the stomach. Chemical digestion also occurs in the stomach. Hydrochloric acid will denature protein, and pepsinogen will be activated to pepsin by the hydrochloric acid in the stomach. Pepsin will begin the breakdown of proteins. Infants also produce an enzyme called renin. Renin will curdle milk. Limited absorption occurs in the stomach, only alcohol and aspirin. What is important in the stomach is the production of intrinsic factor. Intrinsic factor is essential for life. It is required for the intestinal absorption of vitamin B12. Now, should the stomach be damaged or a gastrectomy performed for some reason, B12 may be administered by injection if necessary. People who have complete gastrectomies don't produce intrinsic factor, but they do have to take B12 injections for the rest of their lives. Gastric secretion is regulated through both neural and hormonal controls. Neural stimulation will begin with the vagus nerve. Acetylcholine will stimulate the secretion of gastric juice. This is a long nerve reflex. The sympathetic nervous system will inhibit secretion. There are short nerve reflexes that are based on local stimulation of the stomach, primarily stretching the stomach. Hormonal control is primarily through gastrin. Gastrin is produced by the G cells. Gastrin will stimulate the secretion of both enzymes and hydrochloric acid. It also stimulates the secretion of gastrin antagonists in the small intestine. Gastric stimulation occurs in 3 phases. The first phase is the cephalic or reflex stage. This lasts only a few minutes. It's triggered by the aroma, taste, sight, or even the thought of food. This particular reflex is a long-acting reflex. It acts via the vagus nerve. It prepares the stomach for incoming food. The stomach needs to get ready to digest. The gastric phase lasts 3 to 4 hours. This one is stimulated by the distension of the stomach, by peptides entering the stomach, or by low acidity in the stomach. Long reflexes are involved. Impulses go to the medulla and then back to the stomach via the vagus nerve. Chemical stimuli also can act during this phase. Partially digested protein, caffeine, or rising pH will activate the gastrin-producing cells. Gastrin, you'll remember, causes the release of enzymes and hydrochloric acid. Initially, protein will buffer the hydrochloric acid, so the more protein in your meal, the more hydrochloric acid that's produced. Increasing acidity, that is, as the stomach gets more and more acidic and the pH goes down, is one of the things that will decrease gastrin production. The sympathetic nervous system will also inhibit secretions. The third phase of gastric stimulation is the intestinal phase. Partially digested food begins to enter the duodenum. The intestinal mucosal cells release intestinal gastrin. Now, this intestinal gastrin briefly stimulates the gastric glands, but then starts to inhibit them. As the duodenum becomes more distended with acidic, fatty, or hypertonic chyme, neurons and hormonal signals are activated that trigger a decrease in gastric activity. Basically, the intestine now has to slow down the stomach a little bit, make sure digestion is complete in the stomach before the material comes to the intestine. This protects the intestine from the acidic stomach contents and also prevents us from overwhelming the absorptive capacity of the duodenum, the first part of the small intestine. The enterogastric reflex is the one that inhibits acid secretion of the stomach, so we turn off the acid pumps. Also, secretion of enterogastrones, particularly secretin and cholecystokinin, occur, and this does things to slow down the stomach as well as prepare the duodenum for the digestive processes it has going on. Gastric motility is regulated through several factors. Initially, there is a response to the stomach filling. This is called receptive relaxation. As food begins to enter the stomach and the esophagus, the stomach muscles begin to relax. they have something called gastric accommodation, or the stress relaxation response. When they're stretched, they initially contract slightly and then relax. So as you continue to stretch them, they continue to relax up to a point. Then gastric contractile activity begins. The stomach is involved in peristalsis. Peristalsis is that movement of material through there. And the stomach is a gentle rippling movement. It increases in force as you get to the pyloric end of the stomach. The pylorus only allows liquid and very small particles through the pyloric sphincter, so the most vigorous activity occurs in the pyloric region to make sure we have liquefied that food. We can change the strength of the peristaltic contractions in the stomach, but the timing is always 3 per minute. There are some enteric pacemaker cells that are between the smooth muscle layers that make sure the muscles contract 3 times per minute. The same factors that increase gastric secretions also increase the strength of the stomach contractions. So the more gastrin that's produced, the more hydrochloric acid, the more forceful those contractions become. So as we look at the stimulatory events of the stomach, the sight, thought of food stimulates the parasympathetic system through the vagus nerve to get the stomach ready by starting to secrete materials. Then as the stomach stretches, we have those long reflexes that come again through the parasympathetic system, and we have short reflexes. These all trigger secretions in the stomach, also increasing stomach motility. Gastrin is truly a hormone. It's secreted by stomach cells, but it gets in the bloodstream. When the blood gets back to the stomach, it causes stomach secretions. And then as we get into the intestinal phase, there is a brief stimulation of the secretions of the stomach. This is very brief because we want the stomach to finish up what it's doing so we can move the food to the next phase of digestion. On the inhibitory side, if there is a loss of appetite or depression, then the cerebral cortex decreases parasympathetic activity. There are fewer secretions made. If there is excessive acidity in the stomach, the G cells will stop secreting gastrin so that we won't produce any more hydrochloric acid. The sympathetic nervous system can do a similar thing if we're under emotional stress. As the duodenum begins to be stretched because the chyme is moving from the stomach into the duodenum, we also shut down gastric stimulation. As the duodenum becomes stretched, we also shut down stomach secretion using the enterogastric reflex and the release of the enterogastrones, secretin and cholecystokinin. These feed into the stomach, stopping the production of these secretions. We basically want this acid to get a little bit buffered before it moves on to the duodenum, which is not set up to handle that high acid content. Usually the stomach is completely emptied within 4 hours after a meal. The larger the meal, the more you stretch the stomach, and the more liquid its contents, the faster the stomach is going to empty. How fast the stomach empties also depends on the contents of the duodenum. As the chyme enters the duodenum, the stretch and chemical receptors will slow stomach emptying. This is part of what the enterogastrones do. Carbohydrates move through your system pretty quickly. Lipids take longer to digest. So the presence of fatty, hypertonic, or acidic chyme in the duodenum tells those duodenal enteroendocrine cells to secrete secretin and cholecystokinin. This is going to decrease the contractile force of the stomach and slow the rate of the stomach emptying. The chemoreceptors and stretch receptors will trigger that enterogastric reflex. Short reflexes will slow down contraction and emptying, and the long reflexes, through the parasympathetic activity, will also slow down contractile forces and the rate of stomach emptying. All of this gives the duodenum an opportunity to prepare for its job. Emesis or vomiting is another form of gastric emptying. It can be caused by extreme stretching of the stomach or duodenum or by irritants in the stomach. Irritants like bacterial toxins, too much alcohol, spicy foods, or even certain drugs. The irritated area will send blood-borne molecules and sensory impulses to the emetic center in the medulla. People usually start to feel nauseated, They look pale and they salivate. You'll remember that salivation is one of the things the body does to try to dilute down those toxins. There's a deep inspiration that precedes vomiting. The diaphragm and abdominal muscles contract to increase the intra-abdominal pressure, and the gastroesophageal sphincter relaxes to allow the food to get up the wrong way, and the soft palate will block the nasal passages. So you have this forceful ejection of food in the wrong direction from the gastrointestinal system. Excessive vomiting can lead to dehydration, electrolyte imbalance, and acid-base imbalance.